Assalamu alaikum and good morning. Today we are going to look at testicular pathology. These are the learning needs for this lesson. We are going to discuss cryptorchidism and association with neoplasia. We're going to briefly describe the causes of testicular inflammation, describe the pathophysiology of testicular torsion, classify testicular tumors, describe the etiology and clinico-pathological features of seminoma, non-seminomatous tumors, and sex-cord gonadal stroma tumors. Two structures that we are going to look at are testis and epididymis. The major lesions in the testes are tumors, and the major lesions in the epididymis are inflammatory conditions. Both the testis and epididymis can be simultaneously involved. Three main cells within the testis, and there are the germ cells, the Sertoli cells, and the Leydig cells. All three of these cells can give rise to tumors in the testes. We look at the first testicular pathology, which is non-neoplastic and congenital pathology, cryptorchidism and atrophy. Cryptorchidism is undescended testes or failure of normal descent of testes within the scrotum. This is the most common developmental abnormality involving the testes, which occurs around 1% of 1-year-old boys. The descent of testes has two phases. The first phase, which is transabdominal, is the testicular movement across the abdomen to the entrance of the inguinal canal, and this is controlled by Mullerian inhibiting substance hormone. The second phase, which is inguinoscrotal phase, whereby the testes move through the inguinal canal into the scrotum, and this is dependent on androgens. A normal hypothalamic pituitary gonadal axis is a prerequisite for testicular descent. Testosterone and its conversion to dihydrosterone are also necessary for continued migration, especially during the inguinoscrotal phase. The defect is usually within the second phase. Defect in first phase descent is uncommon. Most of the cryptorchid testis is found in the inguinal canal, and patient is usually asymptomatic. This anomaly is found unilateral in 75% of cases and bilateral in the rest of the cases. Grossly, the testis will be atrophic. Which one of these two do you think is the atrophic testis? Other conditions that can cause bilateral atrophic testis are chronic alcoholism, hypopituitarism, chemotherapy or radiation, and severe prolonged illness. Microscopically, there is a rest in the development of germ cells. Spermatogenesis is inefficient at body temperature. There is going to be thickening and hyalinization of basement membrane, and Leydig cell hyperplasia are seen. The dangers of undescended testes includes infertility, especially if the cryptorchidism is bilateral. One contributing mechanism for reduced spermatogenesis in cryptorchid testes is temperature. The temperature of testes in the scrotum is at least a couple of degrees cooler than in the abdomen. Bilateral cryptorchidism will also cause lower testosterone level. Testicular trauma and inguinal hernia is also another dangers of undescended testes. An important danger is increased incidence of cancer early in life. It affects 1 in 500 men with one or both testes undescended. There is a 10-fold increased risk for testicular cancer. The most common type is seminoma. Now we look at epididymitis. Inflammatory conditions, as we said earlier, are commoner in epididymis than testis. Acute or chronic inflammation of the epididymis is caused by either infection or trauma. Common pathogens in those less than 35 years old include sexually transmitted Neisseria gonorrhea, and Chlamydia trachomatis. Common pathogens in those more than 35 years old include E. coli and Pseudomonas aeruginosa. Mycobacterium tuberculosis begins in the epididymis and then spreads to the seminal vesicles, prostate, testicles, and this is a caseating granulomatous inflammation. The clinical feature of epididymitis includes unilateral scrotal pain with radiation of the pain into the spermatic cord or flank. There is scrotal swelling and epididymal tenderness. Urethral discharge is commonly present if it is sexually transmitted. Pransine is present. Pransine is elevation of the scrotum, which decreases the pain. Positive pransine points towards epididymitis. Negative pransine indicates there is no pain relief with lifting the affected testicle, and this points towards testicular torsion. Urinalysis usually reveals pyuria or increased neutrophils, and Doppler ultrasound shows normal or increased blood flow. Next, we look at testicular torsion, which means the twisting of the spermatic cord that may cut off the venous drainage to the testis. Usually the large arteries are patterned, and this still pumps blood to the testis, so when there is twisting of the spermatic cord, the testis will be engorged with the pumping of blood from the arteries, and you will have red infarction as seen in the picture. There are two types of torsion: neonatal torsion, which occurs after birth or in utero, which is not associated with any anatomic defect, and also adult torsion, which occurs usually in the adolescent, where there is bilateral anatomic defect. The testis has increased mobility, and this is called Bell-Clapper abnormality. This leaves the testis free to swing and rotate within the tunica vaginalis of the scrotum. Next, we look at varicocele, which is dilated veins in the pampiniform plexus of the spermatic cords. This is usually seen in the left testis. This condition usually presents between 15 and 25 years of age, and is rare after 40 years of age. The most common cause of left-sided scrotal enlargement in adults is varicocele. The left spermatic vein drains into the left renal vein at a 90-degree angle, where there is an increased resistance to blood flow because of the small caliber of the vessel. Blockage of the left renal vein causes backup of blood into the left spermatic vein, leading to incompetency of the valves and development of varicocele in the scrotal sac. This concept is similar to the concept of varicose vein in the legs. In the right testicular vein, it drains into the vena cava, and therefore there is no increased resistance to blood flow in the large caliber vena cava. Clinical findings of varicocele includes heaviness or dull ache in scrotum with prolonged standing, dragging sensation in the affected testicle, and visible bag of worms that is observed when standing, disappears when lying down, and increases in size with a Valsalva maneuver. The complications include infertility and failure of left testicular growth. Diagnosis is by ultrasound. Now we look at hydrocele, which is a collection of serous fluid between the two layers of the tunica vaginalis. This is the most common cause of scrotal enlargement in boys and is often associated with testicular tumor. Tunica vaginalis fails to close, and therefore fluid accumulates in the serous space between the layers of tunica vaginalis, and this is associated with indirect inguinal hernia. The diagnosis uses ultrasound, which distinguishes fluid versus a testicular mass that causes scrotal enlargement. The complications include infection and inguinal hernia. We move on to the neoplastic pathology of the testis. The neoplasm of the testis can be either germ cell tumors, sex cord gonadal stroma tumors, and lymphoma. Under germ cell tumors, it is further divided into seminoma and non-seminoma, which is further classified as embryonal carcinoma, yolk sac tumor, choriocarcinoma, and teratoma. Sex cord gonadal stroma, it can be further divided into Leydig cell tumor or Sertoli cell tumor. Germ cell tumors are highly aggressive mostly and can have mixed germ cell tumors having more than one type. The non-germ cell tumors are derived from the stroma or the sex cord. They are mostly benign, but some are hormone producing.
Germ cell tumors are the most frequent and important tumor in the testis. It mainly affects young males, with the incidence increasing after puberty and peaks at late 20s and 30s. The incidence is increasing in rich societies. In Northern Europe and North America, it is the most common cancer in men aged 15 to 44. Epidemiologic evidence suggests it is associated with Western lifestyle, with high calorie intake and lack of physical exercise. It is associated with testicular dysgenesis, cryptorchidism, hypospadias, poor sperm quality, and Klinefelter syndrome. Germ cell tumors are pluripotential tumors in that they can differentiate into both extraembryonic and embryonic tissues. It can differentiate along the gonadal lines to form seminoma. Germ cells can transform into totipotential cells into embryonal carcinoma, which further divide and differentiate along three germ cell lines to form teratoma, or it differentiates along embryonic line to form choriocarcinoma or yolk sac tumor. There is a premalignant lesion for germ cell tumor, and it is called germ cell neoplasia in situ. It is previously known as intratubular germ cell neoplasia. Most tumors arise from germ cell neoplasia in situ, and 50% of untreated germ cell neoplasia in situ develops into invasive germ cell tumor in 5 years. The risk factors for germ cell tumors include cryptorchidism, testicular dysgenesis syndrome, and genetic factors. In cryptorchidism, there is a 10-fold increased risk for development of germ cell tumor. The higher the location of undescended testis, the higher the risk for development of germ cell tumor. Testicular dysgenesis syndrome is a hypothesis that proposes germ cells that are not properly nourished by Sertoli cells during fetal gonadogenesis undergo a delay in maturation, resulting in increased risk for subfertility and germ cell tumor formation. Infertile men have increased risk for germ cell tumor development, and so does patients with androgen insensitivity syndrome, testicular feminization, and Klinefelter syndrome. Regarding genetic factors, blacks in Africa has extremely low incidence of germ cell tumors compared to whites. There is a malignant transformation of germ cells that results from a multi-step process of genetic changes, and one of the earliest events that are seen is increased copy number of chromosome 12p. This isochromosome of short arm of chromosome 12 is found in almost all germ cell tumors, including the ovarian germ cell tumors. The most common clinical presentation is painless testicular swelling. It is wise to consider all testicular swelling neoplastic until proven otherwise. A third of the patients present with dull ache or heaviness in the scrotum, and 10% presents with evidence of metastasis. 5% of patients present with gynecomastia. Differential diagnosis of germ cell tumors include torsion, epididymitis, and hydrocele. and evaluation includes physical examination, scrotal ultrasound, and serum marker for alpha-fetoprotein, beta-HCG, and LDH, CT of the chest, and abdomen and pelvis. Regarding tumor behavior, seminomas tend to localize in the testis for a long time, but non-seminomatous germ cell tumor is generally aggressive and metastasis is found early. This picture shows the chest X-ray of a patient with testicular cancer, and you can see multiple lesions within the lungs. Germ cell tumors spread either via lymphatic pathway or hematogenous pathway. Lymphatic spread is more common in seminoma, especially to para-aortic lymph node. Hematogenous spread is more common in non-seminomatous germ cell tumors, and it spreads to the lung, liver, brain, bone, and kidney. This is a picture of a teratoma that has spread from the testis to the pelvic region. The management of germ cell tumors include surgery, radiotherapy, and chemotherapy. The surgery that is done is orchiectomy. We do not biopsy germ cell tumors because there is a risk for seeding of the tumor. Seminomas are extremely radiosensitive, and non-seminomatous germ cell tumors are radio-resistant. Germ cell tumors respond well to chemotherapy, which includes bleomycin, etoposide, and cisplatin. Note that the side effect of bleomycin is interstitial pulmonary fibrosis. Germ cell tumors has the best prognosis among solid tumors, and testicular cancers are considered curable even in the presence of metastatic disease. The 5-year survival rate is about 95%. Seminoma has better prognosis than non-seminomatous germ cell tumors. The worst outcomes are with metastases, relapse in organs, including the brain. Some germ cell tumors secrete hormone and enzyme. Alpha-fetoprotein is seen in yolk sac tumors. This is a serum protein that is seen in early fetus and is produced by the fetal gut, liver cells, and yolk sac. And normally, serum level falls and is undetectable in adults and children. Human chorionic gonadotropin is normally produced and secreted by placental syncytial trophoblast. Elevated levels are seen in patients with choriocarcinoma. And lactate dehydrogenase is produced in many tissues, including skeletal and cardiac muscle. So the elevation is not specific to testicular tumors. The degree of LDH elevation correlates with the mass of the tumor. The bigger the tumor, the higher the LDH level. Thus, the levels provide a tool for tumor burden assessment. We move to the first germ cell tumor, which is the most common type of germ cell tumor, seminoma. It affects people in their 30 to 35 years old and more than 60 years old. It may be mixed with other types. The prognosis is excellent compared to non-seminomatous germ cell tumors. They are extremely radiosensitive, and grossly, they show homogeneous gray-white lobulated surface affecting the entire testis. Hemorrhage or necrosis are uncommon in seminoma. This is the classic microscopic feature of seminoma. The neoplastic cells display large round cells with distinct cell membrane, clear cytoplasm, and a large central nucleus with prominent nucleoli. It is sometimes described as a fried egg appearance. It is separated by fibrous trabeculae containing T lymphocytes. Next, we look at embryonal carcinoma, which affects people in their 20s to 30s. It is more aggressive than seminoma and more frequently present with testicular pain. It is less radiosensitive than seminoma. Grossly, it shows necrotic or hemorrhagic mass, just like in the picture, and usually do not involve the entire testis. Local extension to tunica albuginea into epididymis can be seen. Microscopically, the tumor cells resemble cells in very early embryo, and the cells grow in alveolar or primitive glandular pattern. The next tumor is yolk sac tumor, which is also known as endodermal sinus tumor. It is seen in two distinct ages. The first one is in infants and young children, and another in post-pubertal male. It is the most common testicular tumor in infants and children less than 4 years old. Grossly, it shows homogeneous yellow-white tumor. Histologically, in yolk sac tumor, there are cytoplasmic or extracytoplasmic eosinophilic globules, which contains alpha-fetoprotein and antitrypsin. Alpha-fetoprotein in tumor cells is highly characteristic of yolk sac tumor. The globules can be seen pointed by the arrow. There are also structures resembling endodermal sinuses seen in yolk sac tumor, and these structures are called Schiller-Duval bodies. Next, we look at choriocarcinoma, which affects people in their 20s to 30s. This is highly malignant and is composed of both cytotrophoblasts and syncytiotrophoblasts. The syncytiotrophoblasts is producing HCG. Most patients present with advanced stage, and this tumor can also produce gynecomastia because HCG is an LH analog. Grossly, it presents as a small lesion in the testes, usually do not cause any testicular enlargement, but they present with hemorrhage and necrosis, which is seen in the picture. Histologically, choriocarcinoma shows presence of cytotrophoblast cells with multinucleated syncytiotrophoblasts, and there is prominent hemorrhage and necrosis. The next type of germ cell tumor is teratoma. This is a tumor composed of several types of tissue representing different germinal layers, which are endoderm, mesoderm, and ectoderm. Grossly, the tumor is usually large, has heterogeneous appearance, and it may have solid cystic areas or mixed solid cystic areas. Microscopically, we can see all three types of germ cell layers, which are the endoderm component, mesoderm component, and ectoderm component. The endoderm component can be from the GIT, respiratory tract, endocrine, liver, or pancreas. The ectoderm component that is usually seen is from the skin, the brain, and the mesoderm component that we see is from the cartilage, bone, and muscle. The components may be mature or immature. Immature teratoma is considered malignant. Some of the endoderm component, mesoderm, or ectoderm component can also undergo malignant transformation. For example, we can see squamous cell carcinoma in the teratoma. Teratomas are usually benign in children and malignant in adults. The differentiated mature teratoma is common in children, and this carries a good prognosis. But in post-pubertal males, all teratoma are regarded as malignant and capable of metastasis. This is regardless whether the component is mature or immature. 60% of testicular tumors are composed of more than one pure pattern, and these are the mixed type. Common mixtures include teratoma with areas of embryonal carcinoma and yolk sac tumor. You can have seminoma with embryonal carcinoma or embryonal carcinoma mixed with teratoma. Apart from the germ cell tumors, there are also tumors of sex cord gonadal stroma, which can involve the testes. Two most important group is the Leydig cell tumor and the Sertoli cell tumors. Other types of tumors that can affect the testes are granulosa cell tumors and thecoma fibroma tumors. This group of tumors constitute about 4 to 6% of adult testicular tumors and 30% of testicular tumors in infants and children. Leydig cell tumors affects people in their 20s to 60s. They present with painless swelling and may present with gynecomastia. They may produce androgen, both estrogen and androgen, or they can produce corticosteroid. This tumor can cause precocious puberty in children. The picture shows a tumor that shows golden mahogany brown color, and it has circumscribed homogeneous surface. Remember, this tumor produces a steroid type of hormone, so it is derived from cholesterol. So the tumor shows this golden yellow color. Microscopically, the tumor resembles the normal Leydig cells. It has large polygonal cells with round nuclei, with single prominent nucleolus and abundant eosinophilic cytoplasm. The cytoplasm is filled with lipofuscin, and we can also see Reinke crystals within the tumor. The next type is Sertoli cell tumors, also known as androblastoma. This tumor is composed of Sertoli cells, but you can have a mixture of granulosa cells within the tumor. They present with testicular swelling and may produce estrogen or androgen. Usually, the hormones that are produced is not much to induce precocious puberty, and this tumor can cause gynecomastia. Histologically, the tumor cells are arranged in trabeculae and they form structures resembling seminiferous tubules.